Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, I know you look at me and you think, wow, here's a man of the world. He's been to all the raves. He's done anything going around. I haven't. And so that's why I'm so fascinated that all of that subculture that I haven't partaken of is now coming up in the form of the thrust of this episode, which is using MDMA in a clinical setting.
That's right. So this is the application of what people would know as ecstasy.
Yeah.
So the street name of the drug ecstasy, which got its name in the 1980s, but it's an interesting path that this chemical, this drug has weaved. And the part that's almost being unable to sort of pull apart is there's a philosophical, like a political undertone of ecstasy, of MDMA. So I will stumble on that acronym several times, so I apologize. But there is, even if people have taken it, haven't taken it, regardless, a lot of people have opinions about it. And this is really looking at it. We're not talking about the street drug of ecstasy or the legal ramifications or any of that. We're actually talking about the medical application of this. And it is important. It is actually really useful. The evidence coming through now is very strong that is useful, particularly in places of like psychedelics in psychiatry and particularly post-traumatic stress disorder. And this is where this has gone down this path. It has a history though. And that's the history is such that some of it is unfounded and some of it is probably warranted. It's a drug. It's a recreational drug, and that comes with a lot of baggage. And if we look at it, it was actually created in 1912 by a chemist, Anton Cloche, and he ended up creating it. But what they were trying to create at the time was a clotting agent. So they were actually trying. There was something on the market at that time. It was called hydrostinin. And this was a clotting agent that had taken over the market, and Merck wanted a piece of that market. And so they started developing chemicals that would go down and help clot. Now, that seems really unusual today because we're not interested in clots today. We're interested in thinning the blood. So to speak. Yeah, that's right. But if you think about it, what they were trying to do was to get an agent that you get a cut, and you put something on it and it helps stop the bleeding. Now, we use pressure these days. We know that's the best thing. But imagine if you had something over 100 years ago, put something on it, it stops the bleeding. Now, it was actually, if you go into the literature, what they talk about is that it was actually produced for an appetite suppressant, which is not right.
The appetite suppressant, and then see if it can apply itself to clotting?
People say, this was designed as an appetite suppressant, and that's actually not true.
Right.
And if you think about it, in 1912, who needed an appetite suppressant?
Exactly.
So, but what they ended up doing was they tried to find this, and this was in 1912, they tried to find this clotting agent. Now, they ended up patenting it, but people say, well, they must have found something useful. No, the pharmaceutical company patented everything because they wanted to make sure that they would protect their pathway that they were finding of clotting. Yep. And so this was a business decision. There were no tests done at this point in time. They just ended up patenting whatever they could and put your name on it. Imagine a pharmaceutical trying to make money, I guess. So, yeah.
Wow. Unusual.
Yeah, that's right. And so what this was, the actual MDMA did not have a name at that time, and it was but they patented everything. So it was in 1927 that the chemical was revisited, and they started doing experiments on animals, but they didn't find any significant findings. And they said, well, maybe we should come back to this. They gave it this name a little bit later. It was called methylsafran amine. And that's whatever name they were wanting to give.
As it turns out, as we'll hear through this episode, that's probably easier for you to say than MDMA.
Well, that's right, yeah. And so, but it didn't go anywhere. And then we start to see experiments by the US government, the Army, in the 1950s, and they were experimenting on animals and toxicity. I can't find much information about why they were trying this. It seems it just goes off into the ether a little bit.
So to speak.
Yeah, that's right. But in the 1960s, we find it resurface, and it resurfaced by a Chilean psychiatrist named Claudio Naranjo. And he began to use it to facilitate psychotherapy. And so, again, there's a bit of a divide in the drug's not around for 50 years or so, and then it starts to resurface in pretty much psychiatry. Now, he found that patients began to open up when they were given some of this drug. They had intense emotions, and it gave access to suppressed memories and insights themselves. And this therapy was not widespread. It was not widely adopted. And so it ended up going into this kind of underground therapy sessions in this psychotherapy. And then we find it in the 1970s, and this is where it started to hit the recreational scene, the drug scene. And the first drug bust is actually in the 1970s, was on the streets of Chicago, where they found a whole bunch of these tablets of these psychedelics. And the first trials we come across is in 1978. Now, this is by Alexander Shulgin. Now, he became known as the godfather of psychedelics. He had a lab set up. He was creating hundreds of psychedelics. He wrote books. He was an advocate for it. And I'm
going to make an offer that will make you happy.
That's right. And he ended up getting to the point of becoming so prominent that the government raided and stripped his lab from using it, because it wasn't a known, it wasn't accepted. It was a drug that was unregulated. And so that's when we come to the 1980s, when it got the street name Ecstasy, and it's clearly being used recreationally. And the government became very interested and probably very critical of the psychedelics, and they ended up putting it as a Schedule 1 and then banned its use. And so this is where we hit the history of the war on drugs, on the just say no.
Yep.
And these drugs, psychedelics, fall pretty much firm into where this is altering your brain chemicals and all kinds of problems with abuse. And the hard thing is there are things linked like deaths and abuse, and you never really know, but people can then label it, though they were using psychedelics, it's dangerous to use. And even medicine and science got into this point. In 2002, the journal Science published an article from Johns Hopkins University. Now, they did a study that was of 10 squirrel monkeys and baboons, and they were injected with large doses of MDMA. And 2 of the animals died, and then it was heavily publicized that a single dose of this ecstasy could cause permanent brain damage. A year later, though, the article was retracted. And it wasn't ecstasy that they had been injected with. They'd been injected with methamphetamines.
Oh.
But the label stuck. If you were retracting an article, there was a number of other experiments that had to be retracted because of this error. And so you can see there are both sides passionate about advocacy for and against. And this is where we find ourselves as the evidence begins to mount, that we have organizations that are experimenting with patients in the setting of managing and treating post-traumatic stress disorder because of
Hang on. Sorry, Tim.
So good. It's gone now.
Oh, it's gone. So just pick up from that last. Yeah. Sorry, Tim. Here we go.
So on both sides, we have advocacy, people passionately for, passionately against. And again, we will come back to the point, this is not talking about advocacy for recreational use and let psychedelics out. This is about what is the medical application for something such as MDMA in medicine. Can we treat patients? Can we help them heal? Can we give safe doses? And what we're finding is the answer is actually, particularly for post-traumatic stress disorder, yes, we can, but we just need to make sure we find a safe path for this.
Yes. And just underlining the fact about it's not focused on the recreational use, because people take it to be happy and in bliss. Whereas for me, I just spend a bit of time in the studio with you, Dr. Travis Brown. Dr. Stephen Bright is a clinically trained psychologist and works in mental health and the alcohol and other drug, or AOD, field for the past 20 years. He's a senior lecturer of drug studies at Edith Cowan University and conducts research into psychedelic science. He's an advocate for an evidence-based approach to AOD legislation and has provided evidence to parliamentary and coronial inquests. Stephen's a co-founder of Psychedelic Research in Science and Medicine, known as PRISM, an Australian non-profit research association that develops, initiates, coordinates and supports formal research into mainstream medical applications of psychoactive compounds known as psychedelics, primarily MDMA. Today, we'd like to welcome Dr. Stephen Bright as our guest on this Medical Life podcast. Stephen, welcome.
Thanks for having me.
I am a great fan of Sam Harris's work in the field of mindfulness, so I'm quite intrigued to hear what you're going to say, because he, along with many American podcasters, are quite open with their experimentation with psychedelics, especially from an evidence-based perspective.
Yeah, look, I guess one of the differences is that MDMA often is conflated by the media with psychedelics. Technically, MDMA is not a psychedelic, and the effects are quite different, and the therapy itself is quite different as well.
All right, well, that's why we're doing this podcast, to get some clarity. And I'd like to start. Can you tell us a bit about PRISM?
Sure. So I was at a conference in 2010 that Dr. Rick Doblin was presenting at, and Rick Doblin established the Multidisciplinary Association for Psychedelic Studies, which is the main organization worldwide that's been coordinating research into MDMA-assisted therapy. And Rick is a very charismatic fellow, and he was presenting the results of the world's first phase 2 clinical trial into MDMA-assisted therapy for post-traumatic stress disorder. And he encouraged us or had us believe that we could replicate something similar and conduct this sort of research in Australia. And so this was late 2010. And so early in 2011, myself and two colleagues, Dr. Martin William and retired Major Steve McDonald, formed PRISM with the explicit aim of trying to establish an MDMA trial here in Australia. And over time, of course, the scope of PRISM widened to psychedelic research more broadly, with a sponsor of the St Vincent's Melbourne trial of psilocybin-assisted therapy for people with end-of-life anxiety and depression. And of course, myself, I'm the principal investigator of Australia's first trial of MDMA-assisted psychotherapy here in Australia. So, in many ways, we've met our key objectives. And I think at the moment we're sort of reevaluating what it is that we might do next.
So most people will be aware of ecstasy or MDMA as a party drug in that field. But what conditions are we considering MDMA usage for in medicine?
So the evidence at the moment is strongest for the use of it in the treatment of PTSD. There is also some research to indicate that MDMA-assisted therapy could be useful in reducing social anxiety among adults with autism. And there's actually a trial that's about to start at the University of Melbourne looking at that particular indication, which is building on past research, but really PTSD is where the evidence is strongest. However, MDMA was being used in medicine before it was prohibited as a drug. In fact, the story of MDMA is actually very similar to the story of LSD, where you've got all this medical research happening. The drug sort of escapes the medical environment. People realize it has recreational value. moral panic ensues, the drug is banned. And so LSD was banned. MDMA came along in the late 70s and replaced LSD in many respects as a pharmacological enhancement to psychotherapy. And back then it was being used to treat trauma, but it was also being used in couples therapy. And so I think as we move forward, we might be looking at other potential indications for MDMA.
Oh, something caught me there. How was it used in couples therapy?
Well, I don't know too much about it, but if you're familiar with the effects of MDMA, and it makes people quite open, empathic, really understanding of the other person, it makes a lot of sense that if you give a couple that are having problems MDMA, that they will open up to each other for a good 6 to 8 hours. And provided that is then integrated into their life, then it would, have significant therapeutic value. I think, in terms of recreational use of MDMA, the reason we know that the psychotherapy is so important, the preparation, which sets up the mindset, the setting it occurs in, and the integration afterwards, the importance of that is highlighted in the fact that, people that are taking MDMA at festivals every year in Australia are not spontaneously recovering from PTSD.
So then if we focus on PTSD, so how does it compare to traditional cognitive behavioral therapy?
The way in which it's delivered is quite different. It's non-directive. CBT is quite directive. You use Socratic questioning to get the person to reframe their perspective about situations. The techniques for depression, anxiety, PTSD, the techniques are all very similar in terms of that Socratic questioning. With MDMA, what's fascinating about it from my experience so far has been, particularly in watching videos during my training in the therapy, the participants seem to have just engage in spontaneous reframing. So it's very non-directive. It's really trusting that the person under the influence of MDMA is going to have those aha moments themselves, rather than requiring that very directive questioning to get there. And so I guess what I've observed is it seems like in an MDMA session, which by the way goes for up to 8 hours, 9 hours, it does seem like it's 10, 12, maybe 15 sessions of CBT condensed into one in terms of what the person gets out of that one session.
Can you tell us then, what does a MDMA assisted therapy session look like?
So the treatment protocol itself is 18 weeks in length, and there's something occurring every week, whether that's measurement of the person's PTSD with an independent rater, or the 1.5 hour psychotherapy session. So we start with a comprehensive screening and assessment process to make sure that the people meet, that they don't have any contraindications. We then start the psychotherapy process, which is really about preparing the person for the MDMA dosing session itself. The therapy, MDMA assisted psychotherapy, it's guided by a couple of principles. One is a bit like Sam Harrison mindfulness. We want people to come into the situation with a beginner's mind, to sort of set their expectations aside, to be curious about what comes up and try not to put judgment on it, but just explore it and challenge it. It can be quite challenging. And so we encourage sort of this in and through approach, rather than pushing against and avoiding challenging experiences, but really leaning into that. And finally, it's based on this principle that people have an inner healing intelligence, which I have to say, when I was first exposed to this concept, I thought was a bit hippy dippy woohoo for me, but it does make a bit of sense. And it sort of fits with a humanistic approach to psychology, or psychotherapy, in which, it's thought that people have within them the resources to change. And so the trainers, Michael Mithofer and Annie Mithofer, who are sort of the patriarch and matriarch of MDMA psychotherapy at the moment, have been for the last 20 years. Michael was an emergency department physician, and he explained to us that when somebody comes in with a serration or a cut, he doesn't heal the person. What he does is he cleans up the wound, he might stitch it up, and he provides the optimal conditions for healing, but the body actually heals itself. And so what we're trying to do with MDMA therapy is create the conditions for the person to be able to heal themselves.
Stephen, I'm glad you touched on that. There's this sense that maybe the answers, if you like, are within us. And I wonder if there's a juxtaposition. I interviewed Rabbi Brash many years ago, very famous rabbi who does a lot of distilling of wisdom culture. He said there are many pathways to the top of the same mountain. Do we think the Socratic questioning in CBT and other therapies is one way to tap into that versus, in this case, MDMA, which is using chemical pathways to unblock our access to what might lurk within?
Yeah, I think I haven't heard it quite described that way with MDMA, but I think that holds some potential validity. I have, however, heard of psychedelics described the same way, in that, that mindfulness and meditation can take you to the top of the mountain, and psychedelics are a bit like a helicopter ride to the top of the mountain, so you can see what's going on, but it then gives you the motivation to continue to engage in those contemplative practices because you've seen what's up the top.
Mm. Now, when we say the actual sessions, when I say what do they look like, I've seen images of pretty much a bed and two seats sitting beside the patient, and if that can take 8 to 9 hours, is that meaning that you have two therapists looking over a patient all that time, or is it coming and going as you please, or is it checking in? What kind of therapy is happening there?
It's a really good question, and a really good point is that what makes this therapy different is the involvement of a co-therapy team, and it's typically a male-female team, and it's partly to assist with some of the countertransference processes that take place during the MDMA session. MDMA really amplifies the transference process, and so it's sort of replicating the mother-father by having a male-female there. It's also for safety reasons. MDMA can make people very vulnerable, and of course, in the research, all of the therapy sessions are videotaped for training purposes, to make sure we're adhering to the treatment, but also for safety reasons as well. And if somebody ever wanted to watch something back, we do have that session recorded on video. But to answer your question, yeah, we're in the room for that entire time. So from an economic perspective, it's going to be very expensive to deliver this treatment. In the Perth MDMA trial, we estimate that each treatment is costing about $20,000 per participant. So that's inclusive of 2 clinical psychologists' time. We have a psychiatrist involved as well, which we might come to this a bit later, but with the new TGA authorized prescriber scheme would require something similar. We have a physician monitoring the person. The MDMA sessions themselves actually occur in a hospital and involve an overnight stay, and that's the internationally recognized model. And so a hospital bed's not cheap. The cost of a special nurse to be on to care for that person while they're in hospital. So yeah, it is a very resource intensive treatment. And I think, in terms of thinking about the cost of it, I think we're going to have to look at how much it's going to cost per patient to access this treatment, and whether there's a net saving over time through them. If they are cured of PTSD in the long term, is there a net saving there? In addition to obviously the humanity of it, the person, having quality of life and everything else, we know that politicians at the end of the day, it's the dollar that drives decisions, and that research hasn't been done yet.
Now, a common misconception is that patients are given essentially a party drug and have a great time. What is the reality of a patient with PTSD using MDMA therapy?
Yeah, so like I was saying, the way we establish the set and setting is quite different to recreational use. So the person in a recreational environment is intending on having a fun time. That is their intention. In this therapy, the person sets an intention related to their life, their trauma. And one of the similarities is there is music playing. We use the music to sort of help ground people and perhaps allow them to really focus on the experience. But unlike recreational use, it's very inner directed. The person is encouraged to use eye shades. And they may have, as I say, very non-directed, they may have eye shades on for up to 2 hours with two therapists sitting in a room with nobody interrupting the person. A key part of MDMA therapy is we don't want the therapist to get in the way of the process that's occurring. So we will interrupt the person if it looks like they're having a particularly challenging experience, or we'll interrupt them if it looks like they're not, that they might be having a good time because they're thinking about something else. They've forgotten about their intention. We might just touch their leg and remind them of their intention again. And, the other key difference is, based on all of that, people generally aren't having a good time in an MDMA therapy session. It brings up very challenging material. And that's really the whole point of using MDMA. As I said earlier, it really opens people up. And so it allows people with trauma to think about and talk about parts of themselves and things related to the trauma that they wouldn't really be able to sit with comfortably normally.
I've just finished reading John Cleese's book on creativity, and he talks about the direct link between the mood being stimulated by media you might be consuming and your own mood. I'm a Leonard Cohen fan, and so this is a serious question. Would you let me choose Leonard Cohen as the playlist, given that people dismiss his work as being depressing and down? Is there a particular formula to the music that patients are meant to choose? I know this is getting into the detail.
Yeah, this is good. Yeah. Well, to get into a bit more of the detail around the music, generally we use a version of the MAPS playlist. So very similar playlists are being used around the world. The music it doesn't have any vocals in it. So we might, in the final session, because we usually do 3 dosing days over that 18 weeks of treatment. In the final session, we might allow a track in there if it's particularly personal and relevant for you. But we actually try to avoid music with words in it because that can distract the person from the experience. And so, it's a little bit of classical music, a little bit of sort of new age electronic music, but we do. For us here in Australia, I have to say we're still learning how to do this, and how I say to the participants, I'm a psychologist, not a DJ, but I will do my best. If you don't feel that the music that you're listening to is helpful to your process, if your inner healing intelligence is telling you that this is not helpful, and of course ensuring that this isn't an avoidance strategy because it is helpful, it's just challenging, then we would try to change the music, in terms of the tempo or the style. But outside of that, it's a fairly structured playlist, and it kind of works similar to the way the psychedelic playlists work. It starts off quite slow and quiet, and then within sort of an hour, sort of the tempo picks up, and that tempo sort of holds with a fair bit of tempo with some pauses and slower music in between as punctuation for sort of 4, 5, 6 hours.
Can I ask what results are like with this treatment for PTSD?
Yeah, so the first phase 1 study that I mentioned was presented in Melbourne in 2010. Showed that 86% of participants who had treatment-resistant PTSD no longer met criteria for PTSD at the 12-month follow-up, and at 3.5 years afterwards, that had been sustained, which is, I don't like using the word cure, but that does start to look like a cure for PTSD. There's been 6 phase 2 studies completed. That pooled data showed about 67% of people were no longer meeting criteria at 12-month follow-up. And there's been 1 phase 3 study published, and one's been completed and not published yet. The published study shows similar results, around 2 in 3 people responding. And look, this is really good data, but I think something that does get missed in the excitement is that means 1 in 3 people aren't responding to it, and we don't know why some people do respond and why some people don't respond. And if we move into this new sort of private model of accessing MDMA-assisted psychotherapy, I think we want to know a bit more about who's more likely to respond to it before we start asking people to shell out, $20,000+ to access one of these treatments.
There was one story that you mentioned in a previous lecture about the significance of transference, and you mentioned it earlier before. I think there was one story who the patient actually saw the therapist, the male therapist, as her abusive father. Can you tell us a
Correct.
little bit about some of the risks of this treatment and how it can be quite complicated?
Absolutely. So that's that story that you mentioned. That was a video with Michael and Annie Mithofer, the trainers that trained myself up in this treatment and are overseeing, sort of the way in which this treatment is being provided worldwide. I think some of the risks have already started to raise their head, though they haven't got the impact of media reporting that the positives have. So in a MAPS sponsored clinical trial in Canada a few years back, one of the participants was sort of groomed by the male psychiatrist, and this led to a sexual relationship because, it's like if somebody's drunk, people aren't thinking straight when they're under the influence of these drugs. They're quite vulnerable, and you can see how, well, I find it difficult to see how that happens, but I do understand how it happens, and I think that's a huge risk. We already have lots of APRA reports every year of transgressions taking place. So add MDMA to the mix and we're going to see a lot more problems in that respect. And I think also there's the potential to do damage. You're like the idea of the wound. We're sort of reopening the wound and then exposing, and then sort of ideally creating a safe place and the conditions for that wound to heal. Now, if we don't create the conditions for that wound to heal, we could actually further traumatize somebody or injure them further.
Mhm. So then looking at the other side and the potential benefits, 86% is remarkable treatment because I think CBT is somewhere around maybe 50% over, a long therapy time. Can you tell us how is it thought to actually work?
Well, as I was saying, we don't really know exactly how it works. I guess the neurological or neuroscience explanation would be that MDMA dampens down parts of the brain associated with emotion, like the amygdala. And of course, other drugs like alcohol do that. And, somebody with PTSD that can't talk about their trauma, if they are very intoxicated with alcohol, they may be able to talk about their trauma because of that blunting of the amygdala and emotional response. However, alcohol sort of scrambles the brain and they probably won't even remember talking about it the next day. MDMA also turns on part of the prefrontal cortex associated with language. And so that might be helpful in that reprocessing process as well to particularly what we're talking about with the reframing, that might help the person reframe because certain parts of the prefrontal cortex are being activated. And, ultimately is probably similar in some way to CBT in that there's a window of tolerance that you need to work within. If you're not arousing the person enough, then the treatment's simply not effective. And some people have ways of avoiding so that they keep hypo-aroused. And if we hyper-arouse somebody, then they become re-traumatized. They may drop out of treatment, but they're not going to get better either. And so MDMA seems to work quite well at just holding the person in that window of tolerance, the Goldilocks zone, if you like, for an extended period of time. So that I think, this is just my personal opinion, I think that then allows people to reprocess the trauma in a similar way that CBT does, except we're putting sort of a lot more trust in the person that they're going to do that themselves rather than needing a therapist to ask them questions and to direct them there. But of course, there is some direction. If the person looks like they're avoiding, then we, raise that, and we have things that we've worked out in the preparation sessions to use short words that remind them of what we're here to do.
So then looking at, there are a few patients who aren't appropriate for MDMA therapy. What's the contraindications for this therapy?
Yeah, there's a number of contraindications. Most psychotropic medications are a contraindication, which has been very problematic. Our study is a feasibility study. We're not looking at how effective this is. That research is pretty much being done now. So all we're trying to look at is how might this look practically here in Australia. The biggest difficulty so far has been finding participants with PTSD who meet our criteria of severe treatment-resistant PTSD who are not on SSRI or other antidepressant medications because we've just found it's too difficult to titrate those people off those medications. I gave a presentation in Melbourne in December last year. And it was actually the same conference that was run in 2010. It's called Entheogenesis Australis. Great conference for people interested in this area. And I had to put up a picture of a unicorn because I really feel like that's what we're trying to recruit at the moment. We're looking for unicorns. They're people with severe PTSD that are treatment resistant, that are not taking an SSRI medication. They can't have any substance use problems, which is very commonly comorbid with post-traumatic stress disorder. They can't have a number of psychiatric conditions. Obviously, things like schizophrenia, bipolar disorder, even within the family can be a contraindication. Some personality disorders, particularly borderline personality disorder, which there's a lot of overlap between borderline personality disorder, complex PTSD and PTSD. So there's a lot of overlap there as well. And of course, any medical conditions that might lead to adverse physiological situations. So anybody with hypertension, cardiovascular disease, excluded from the research as well.
So then is there anywhere around the world or even in Australia that this has been approved therapy for use?
So in the US, they currently have compassionate access, which is a bit like the SASB TGA pathway, the special access scheme we have in Australia, which hasn't yet been utilised for MDMA or psilocybin. Of course, it's used commonly for the prescribing of cannabis. In February this year, the Therapeutics Goods Administration announced that they would be making some legislative changes so that MDMA and psilocybin are now included in Schedule 8 as well as Schedule 9. So they are considered, from the 1st of July, they will be considered controlled medicines for the treatment of psilocybin treatment-resistant depression, MDMA, PTSD. So they can't be used outside of that. And because there are no approved medicines in Australia containing those drugs, rather than using the SASB pathway, the TGA is requiring people to become authorised prescribers so that it can only be prescribed by a psychiatrist who is approved by the TGA as an authorised prescriber. And to become an authorised prescriber, the psychiatrist first has to get their treatment protocol that they're proposing to use with the patient approved by a Human Research Ethics Committee. So I really don't see that, in 18 months from now, I don't think things will be that much different to today, because those tight requirements are very similar to what we're already doing in clinical research in Australia anyway. But on one hand, it was huge news because it means that Australia is the first country to legislatively recognise that these drugs are potential medicines. But on the other hand, accessibility is going to be an issue. Not many psychiatrists are going to put their hand up to become authorised prescribers, not only because of the difficult process in getting approvals, but also because of potential insurance risks. This isn't an approved treatment. What's that going to impact, their insurance premiums? There's lots of things to think about. The cost. So we're going to need a psychiatrist. Most psychiatrists aren't trained in psychotherapy. And, just cost-wise, if we have a psychiatrist and a clinical psychologist for 8 hours for 3 days, that's going to rack up a very big bill. And so I think it is good that people are excited about this change, but realistically, it is definitely a step in the right direction, but it is just the first step, and it's a small step at that.
If there are GPs listening who have patients that may satisfy all that criteria, is there any pathways or is there any facilities that they can contact for the management for this patient?
At this stage, there's not, but I think things will change after the 1st of July. I think we will see a couple of clinics set up around Australia that specialise in providing this treatment. I'm a scientific consultant for a company here in Perth called Reset Mind Sciences, and they are producing a GMP psilocybin product originally for research use around the world. So it's being produced using the actual mushrooms themselves rather than a synthetic product. And they thought that could be, an interesting thing that would be of interest for researchers and also in the future for patients. However, given the recent TGA changes, they're thinking now about, we're now producing a product that's going to be available to the local market, and how might we best do that? It might be best done within the context of a clinic that we run and oversee to be able to ensure, to reduce the likelihood that things go pear-shaped, that they have control over. And, I think other clinics like that will set up and potentially look at providing MDMA treatments. But at the moment, my trial's the only one in Australia recruiting. We are unable to take on any more participants at the moment. So we've got a wait list and our wait list is full. Though there are other clinical trials that should be commencing soon in Australia. There's one at Monash University that's being led by Paul Lanatsky at Monash. And of course, the trial I mentioned at University of Melbourne and Origin, that's being led by Jalinda Beatty. But that, of course, isn't for PTSD. That's for people with social anxiety, people with autism experiencing social anxiety.
Stephen, just finally, we do this podcast primarily for GPs, specialists, medical students, etc. Any final thoughts to let linger with our core listeners on MDMA-assisted therapy?
Yeah, absolutely. I think it's good that healthcare professionals are excited about this. I do think this is a promising treatment. There's a good signal in the data so far. However, there are some methodological problems because we're doing randomized controlled trials with these drugs. Now, about half an hour after you administer the drug, everybody knows who got the placebo and who got the MDMA. And that's problematic because of all the positive publicity around these drugs. It means that people in the placebo condition are extremely disappointed. They may have pinned all of their hopes on this, and that's going to amplify the effect size. So yes, I think there's definitely a signal there, but it's probably an overestimate at the moment. And my concern is because there hasn't been this sort of critical analysis of those research findings when they've been presented to the public are very excited about this as well. And desperate people will do desperate things. I am concerned that people that are unable to access these treatments, even with the TGA decision and what happens on the 1st of July, most people are not going to be able to access this treatment. And some will take things into their own hands, including DIY MDMA therapy or accessing underground illegal facilitators and psychotherapists that are already doing this work here in Australia. And obviously that's risky for patients because there's no regulation over who's providing it. There are some good providers, but there are some very problematic people out there doing this as well. And so it is really Russian roulette. It's Russian roulette in terms of the drug itself, without getting GMP MDMA. Street MDMA may or may not contain MDMA. It could contain a host of other things. And so, yeah, I think that my final word for GPs would really be to try to curb the enthusiasm of potential patients, because yes, this is something that's coming. And, if people are not responding to the treatment they're receiving at the moment, maybe this is something that they'll be able to access in the future, but it's going to be a fair way down in the future. It's not going to be in the next 6 to 12 months that people are going to be able to access it. So I think, providing people with realistic expectations around that, and potentially even providing harm reduction if the patient is explicitly stating that they are going to go out and access one of these underground treatments, we can arm GPs with information to be able to reduce some of the risks that people might be exposed to, questions they might want to ask the facilitator to think about, is this the right person I want to put me in this vulnerable position or not?
Wow. Dr. Stephen Bright, thank you for shining a light and refracting it through the prism of this Medical Life podcast.
Love it. Thanks for having me.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjud. This has been a PathNotes Proprietary Limited production.
Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.